Hey everyone, Dr. Ryan here, and in this case presentation video sponsored by Colgate, I'll be talking about the orthodontic treatment that I provided for Sophia. Sophia came to my orthodontic clinic after seeing some Google reviews, and she wanted her smile to look better, especially the upper left canine. That's what she was pointing to during our initial consult, and she's not had orthodontic treatment before. Some health history: she's a 21-year-old female, has a pet dander and peanut allergy, has asthma and ADHD. She takes Singulair to help prevent those asthma attacks and uses an albuterol inhaler as needed as an emergency inhaler in the case of an asthma attack. And she takes methylphenidate, which is used to control the symptoms of ADHD. She didn't see her dentist in over 3 years, so that was a concern, and I did point her in that direction before we started any orthodontic treatment. For the intraoral and extraoral exams, I noted some slight but present mandible and chin asymmetry to the left. So you can see that in the front photo. There's a little bit of deviation to the patient's left of her mandible and chin. We'll talk more a little bit later about why that is. For her oral mucosa, no lesions, masses, or ulcers noted. Her gingiva, though, was a red color. The gingival margins were rounded, and there was no stippling, all of which suggest generalized gingivitis. The lips, tongue, vestibule, oropharynx, all within normal limits, and salivary glands without swelling, masses, or obstruction. Here's her initial scan, the intraoral scan. Notice the blocked out, facially displaced upper left 3, the patient's chief complaint. There's also some heavy calculus accumulation on the lingual surfaces of the mandibular anterior teeth. This is a very common place for tartar buildup because both the sublingual and submandibular glands open into the floor of the mouth near the mandibular incisors and provide the mineral content in order to harden the plaque, because that's what calculus is, mineralized plaque. She also has a crossbite of the upper left 6 and the lower left 6, and that was causing a functional shift to the left. So when the patient first hits in centric relation, she was cusp to cusp at the left 6s, and then she would slide her mandible to the left to reach a full crossbite, which you see here. And so this is what's contributing, this cuspal interference is what's contributing to that facial asymmetry that we noticed before. She's also a class 2 dental malocclusion. She's about half cusp on the right side where the teeth are basically sitting on top of each other. And she's a little bit more so class 2 on the left side. I would say about 3/4 cusp, and some of that to blame on that canine, once again, allowing some of this buccal segment to mesialize. I would also call it class 2 division 2 because of the retroclined upper incisors. And she does have a mild deep bite. So I like the bite to be a little bit more open than this to eliminate any heavy anterior contact between those incisors, which can lead to some unfortunate and uneven incisal wear. So here's her initial panoramic, and we could call these wisdom teeth impacted, but it's more accurate to say that they're unerupted because the patient's only 21 years old, and wisdom teeth could still erupt into your mid-20s. So I would call these most accurately unerupted wisdom teeth. For reference, I do recommend removing jewelry as much as possible prior to taking a panoramic x-ray so you don't get these ghost images that flip to the other side of the x-ray and lift up a little bit, because those could be superimposed over your tooth roots like we have here. So her treatment outline, for past medical history, no contraindications to treatment. For dental history, she does need a dental cleaning and clearance prior to orthodontic treatment, which we did receive. For growth, she's post-adolescent with minimal remaining growth potential. Our problem list, as summarized from what we looked at before, she has severe upper crowding, moderate lower crowding, dental class 2 malocclusion, crossbite, the upper left and lower left 6 with that functional shift, mild deep bite, and some uneven incisal edges. The treatment plan is to bond upper and lower 7 to 7, that's second molar to second molar, LightForce braces and elastics. The LightForce is a 3D printed, fully customized bracket system that I use for my patients. And with the traditional, if we're comparing to the traditional metal or ceramic brackets, we basically have to use the same stock brackets for every patient, whatever our prescription is. There are different prescriptions of brackets. There's MBT, Roth, Damon, but whatever prescription we choose, we have to use the same stock brackets for every patient, no matter what their tooth shape and size is. And so, as orthodontists, we have to customize that appliance by repositioning brackets throughout treatment, bending wires, and using auxiliaries like torquing springs, all of which adds more visits and takes away some predictability because more things can go wrong. So instead of being forced into a certain prescription, the patient becomes the prescription when we use a custom fit appliance like LightForce, where we're 3D printing the brackets for that specific patient's teeth. The analogy that I use for patients is traditional braces is like taking a long trip with multiple connecting flights, while LightForce braces is like taking that same trip but direct flight. The end result is the same, but the way that we get there involves less stopping and less redirecting. And so this is why I have a lower estimate than most braces cases. I comfortably estimated the length of treatment to be somewhere between 14 and 16 months. We'll see how accurate that is when all is said and done. So let's get to the treatment timeline and see how accurate we ended up being. So we started her treatment on August 10th, 2023, and she had a total of 7 regular visits and 2 comfort appointments, which are the ones in red, for a grand total of 9 visits. That's it. I actually underestimated her total treatment time, which was just over 10 months. Unfortunately, throughout treatment, her hygiene improved a lot. Part of that was because she felt more and more confident about her smile, but we did struggle with some loose brackets because, as the patient admitted, she would eat certain things that she wasn't supposed to with braces, and so we had several loose brackets that were coming off, and we had to place those back on during some regular appointments and some comfort visits. Now, I used to call these broken brackets. That was like our code, but broken bracket is an inaccurate term because the bracket itself wasn't breaking, it broke off from the tooth. And so for me, it seems more accurate to say became loose from the tooth. It wasn't the bracket that was cracking or piece of, a tie wing was breaking off of the bracket, which could give the patient the wrong idea that, hey, these brackets are really weak and they break. That's not the case with at least the patients I've worked with. Either a bond failure or too much force being applied to the bracket with something that was hard, chewy, crunchy, all that good stuff. So we started with an 014 nickel titanium wire. That's usually my starting wire for most cases. And we'd advanced to an 1818 nickel titanium. Then we went to, I had to go back to an 018 wire on top because of this loose bracket situation, but we could still advance the lower to an 1825 titanium molybdenum alloy or TMA wire. And so after we could get into a little bit stronger wires, we got into TMA for top and bottom. I started her on class 2 elastics to help with that malocclusion. After everything was aligned, we could close some of the spaces that opened up by advancing to a rectangular wire. And we continued elastics for a bit, but she did a great job with that. So we got really fast class 2 correction. We took our progress pan, and I really liked the results that we were getting. I just had to bend a couple of teeth. I'll show you in the progress pan what I looked at there. And we just continued elastics a little bit longer, full-time left, nighttime right, because we needed more correction on the left side. As you could see from the start, that's where she was more class 2 to begin with anyway. So then once we got the right side locked into class 1, I just had her continue nighttime wear so it didn't relapse or rebound, and we continued full-time left until the midlines were coincident. And then very shortly after that, we removed the braces in June of 2024, and we placed upper 2-2 and lower 3-3 lingual bonded retainers and scanned for clear plastic retainers that fit over those bonded retainers. Not every patient gets bonded retainers. This is an optional thing that I offer to patients, particularly when they have a lot of crowding or they have big spaces between their teeth. I'm highly recommending these, but in some patients they decline, or they had mild crowding, and so the clear plastic retainer is enough for that. So here's the progress pan that we took. This was a metal bracket that I had to replace at one point in the treatment. That's why it shows up a little bit more on the x-ray. Another interesting thing, you can see the upper left 8 in particular erupted a bit more when we compared to the initial pan there. So I did refer to an oral surgeon for evaluation of their extraction. That's all 4 wisdom teeth. And you can see the root tip isn't perfect on the lower right 1 and the lower right 4. Those two kind of stuck out to me on the progress pan. So I did address that with a little bit of wire bending at that appointment. Now check this out. This is the final scan after removal and placement of those permanent retainers. So really happy with the class 1 occlusion here. We got coincident midlines. Not always possible in every patient, and the layperson can't really detect a 2 millimeter or less deviation between midlines, but hey, when they get perfect, that's great. I would have liked to include this upper left 3 in the fixed retainer just because of its starting position, but the lifespan of these retainers goes way down when you include an upper canine, because it's only a matter of time with normal occlusion and canine guidance that the glue pad will ultimately break off. The lower canine, you don't have that issue, but that's certainly something I've seen with the upper canines. And so stuck with the upper 2-2. Of course, the clear plastic retainer will fit over that as well. Also notice the upper left 8 by this point was actually erupting into the mouth. One interesting thing with these wisdom teeth, if they're not covered in the clear plastic retainer and they're not going to be extracted anytime soon, they will eventually supra erupt because everything else is covered except for the wisdom teeth. And so that's why I do like getting them removed, because they tend to cause more problems than they're worth. And if the patient doesn't want to get them removed, then I do recommend having the retainer cover those. Otherwise, they could contribute to some bite issues down the road. So here's her final result. It's subtle, but gaining the lateral overjet and eliminating that cuspal interference on the left side. Remember that crossbite that was there? We fixed that. And that also improved her facial asymmetry a little bit, because instead of sliding to the left to reach that maximum intercuspation, her centric relation and MI positions were now coincident, kind of retrained her musculature with the class 2 elastic as well. So all of that really helped to improve the overall aesthetics there. Super thrilled with the result. She was as well. And thank you so much for watching and listening to this case presentation. I hope you enjoyed, and I'll see you in the next one.